Welcome to Dr. Cruz. We're really happy to have her here with us. She's going to help us guide us on the conclusions on all this information we're going to analyze today. I am Dr. Jaimes, and Dr. Casal and Dr. Sanders are going to present the articles today. So, no more introductions?
Sounds good. That was a short one.
Okay. So we're going to do something a little different than we've done before. We're going to present two articles in a very quick manner. Try to. Okay. We have no financial disclosures. So these are our objectives, which are pretty much the same with each journal club that we have. We are going to practice our PICO-TT format, and we're also going to understand the limitations of a randomized control trial as well as a cohort study with the help of the CAP formats that we have used in the past. We're also going to be we're going to familiarize ourselves with non-inferiority trials, correlation and confounding variables, and we are also going to assess the internal and external validity of our articles. So just like each journal club, we try to come up with a clinical question based on our PICO-TT format. So our PICO-TT is among healthy female adolescents, does contraceptives compared with placebo affect bone density? And this is a prognostic type of question, and theoretically you would like a cohort study to assess this type of question. And remember, the prognostic study is we're looking for the effect of your treatment. So we came up with a bunch of articles thanks to Dr. Jaimes and Dr. Cruz, and doing our PubMed search, we found two articles that are both interesting. So one, Dr. Sanders will talk about using injectable versus oral contraceptives and their effect on bone mass density, and then I will follow it up with using the extended regimen versus the 28-day regimen that we are all more familiar with.
All right, so like she mentioned, I'm going to be talking about the first article, which is the bone mineral density in adolescent females using injectable or oral contraceptives, and this was a 24-month prospective study. And the reason why I chose this article specifically is because I wanted to kind of focus on contraceptives that were a little more, were a little easier for adolescents to actually do on a long-term basis compared to oral contraceptives. And there was no studies that I could find on IUDs at the time. So like we mentioned, this is a prospective cohort study supported by the NIH. Patients were recruited from May 2000 through January 2003, and they were collected from 4 general adolescent health clinics located in metropolitan settings. Their inclusion criteria included girls who had begun their menses and were aged 12 to 18 years old. And at the time, they were either initiating contraceptives with depomedroxyprogesterone acetate, which I will shorten to injectable for the remainder of the talk, or oral contraceptives, or who plan not to receive any hormonal contraception during the 2-year period. And of course, consent was obtained from the parent and assent from the enrollee. Exclusion criteria included anyone who had used injectable contraceptives in the last 6 months, were pregnant, or had an abortion in the last 6 months, as well as anyone who used oral contraceptives within the past 3 months. They had any chronic medical conditions that could have effect on bone mineral density, if they had any reasons why they couldn't be on sex hormones, and if they had any need for confidentiality for their contraceptive management. So For their methods, the follow-up occurred at baseline, so the beginning of the study, 6 months into the study, 12 months, 18 months, and 24 months into the study. At each interval, they collected a variety of information, including menstrual bleeding patterns, general medical symptoms, any medication use. They also obtained a height, a weight, calculated their gynecological age, which is the number of years since they began menses, as well as tobacco use, and that was either current use or non-use, and their calcium intake, which was determined off of a focused 24-hour dietary recall per the patient. Physical activity, which was assessed as either active, inactive, or normal. And then they also obtained a measurement of their bone mineral density, looking at the lumbar spine, the total hip, the femoral neck, the trochanter, and the Ward's triangle using the DEXA scans. And that happened sometime within the 4 weeks of the time that they were seen by the study. The group was then divided based on their treatment options. So patients either received the injectable contraceptive at 150 milligrams IM every 12 weeks, and their compliance was measured by the number of injections they received compared to the number that they were actually prescribed, or they received oral contraceptives with ethinyl, E2 20 micrograms, and I can't say that word, so I'm not going to butcher it, 100 micrograms. And their compliance was measured via self-report. So they reported how many pills they actually took versus what they were actually prescribed. And so just to start going into the results, originally there was 433 adolescent girls that were included at the beginning. 58 were in the injectable group, 187 in the oral contraceptive group, and 188 were in the group where they opted not to start any type of contraceptive. By the end of the 2-year period, only 184 of those girls remained. 27 were in the injectable group, 62 in the oral contraceptive group, and 95. So as you can see, the continuation or the compliance of the study was about 46 for the injectable, 33 for oral, and 51% for the untreated group. And most of the girls that were missed at the end of the study were either due to non-compliance at appointments, or they opted to discontinue the method that they originally chose at the beginning of the study. And they did look and compare baseline characteristics of the patients that were lost to follow-up compared to the patients that did remain, and there was no significant difference in the population. So this is Table 1. Hope everyone can look at, see it okay. And things that I wanted to kind of point out from this table. So this is showing the baseline descriptive data of the participants that were in the study. And the main things we're going to focus on are the things that have arrows next to. So first, you'll notice for the chronological age that the group, the oral contraceptive group, seemed to be a lot older, or older than the untreated group. And that'll come into play a little later when we look at the results. Also, the body weight, gynecological age is similar. They're usually further along in their gynecological age if they're in the oral contraceptive group. As far as the body weight is concerned, the injectable group had a lower body weight compared to the untreated and the oral contraceptive group when you're looking at the numbers. And then looking at the spine and femoral bone mineral density levels, it was higher in the oral and injectable groups, who were also just remember, they're also the older group in the study compared to the untreated group. You'll also see that there was more smokers in the injectable group, as well as the oral contraceptive group compared to the untreated group. Once again, remember that those are the older groups compared to the untreated group. And the physical activity was higher in the younger group, which was the untreated group. So before we move on, the study went into a little bit of detail about correlation, so I just wanted to remind everybody what that was. So correlation is the magnitude of the relationship between different variables in a study, and they use the Spearman-R coefficient to determine that. R is the correlation coefficient, and it signifies the strength between the relationship of the two variables. So it can range from -1 to 1. -1 signifies the strongest possible negative relationship, which means one variable is high while the other variable is low consistently. And then at the other range of an R of 1, that's the strongest possible positive relationship. Both are high or low at the same time. And then, of course, R of 0 denotes no significant relationship between the two variables. So in this study, there was no table that showed this information exactly, but the study found that there was a high correlation between the chronological age and the gynecological age with an R of 0.69, and the p-value for that was 0.001. And they also found a high correlation between the body weight and the body mass index with an R of 0.94 with a p-value less than 0.001. So they opted to choose chronological age and body weight when they went further into the analysis of the study instead of comparing it for all four of those variables. Does anyone have any questions about correlation before I continue? I know I'm talking fast, but so we can get through 2 articles. So compliance for the 2 treatment groups, which was the injectable group and the oral contraceptive group, was determined by the way I talked about earlier. So for the injectable group, basing it off of the number of injections they received versus what they were actually prescribed. And then for the oral contraceptive group, how many pills they said they took. And you'll see that there's a higher compliance rate with the injectable group of 99.4% compared to the oral contraceptive group of 86.3%. And this in Table 2, so this is looking at the absolute and percentage change in the bone mineral density at the lumbar spine and femoral neck comparing the 3 treatment groups. So this is the bulk of the study, I will say. So what you'll notice is, 1, the injectable group had a decreased bone density from the beginning to the end of the 2-year period, which, as we all know, at this point in time in life, you're an adolescent, you're usually adding bone mineral density rather than losing it. And then the untreated group gained bone density of about 6.3% compared to the loss of 1.5% in the injectable group. And this, if you kind of do like an overall additive calculation, is the 7.8% difference for the spine for bone mineral density. Similarly, the untreated group gained 3.8% in the femoral neck compared to a loss of 5.2% in the injectable group, which is a 9% difference. And then there was not really any p-values or any information comparing the oral contraceptive group to the untreated group in this study. So it was really focused on injectable compared to the oral contraceptive and the untreated group. This table is focusing on, they were looking at girls who lost more than 5% of their bone mineral density in the lumbar spine from baseline at any point along the 2-year study. And they found no demographic background or clinical characteristic, which is what they were looking for, that predisposed them to the significant bone mineral density loss when compared to the girls who lost less than 5% or actually gained bone mineral density. And for this table, so they were looking at for potential clinical correlations between girls who were categorized as osteopenia, which is categorized as a lumbar spine bone mineral density more than 2 standard deviations below the mean of the entire group. And what they found is that these participants had significantly lower body weight as well as lower body mass index. And you'll see like a little A next to those 2 categories, and the p-value for that was less than 0.01. They also found that it was significantly, it was more significant in younger gynecologic age females. Any questions before I continue? So we'll start the appraisal of this study. So the first question is, was the defined representative sample of patients assembled at a common, usually early point in the course of their disease? So I'll kind of open it up to you guys to kind of discuss what your opinions are based off of the information that you know. Anyone?
I mean, it sounds like they tried to make sure that all the groups were very similar and starting point, based on what I can tell. It sounds like
Anybody else have an opinion about it? That's definitely what I was thinking as well when I first looked at it.
The age is not the same.
Right. One of your
they're not
older.
All right. So, just to bring back the original table, looking at the chronological age and the gynecologic age, and how we pointed out that the oral contraceptive group, as well as the injectable group, was higher than the untreated group. It also is shown by the fact that the spine and femoral neck bone mineral density is higher in the oral contraceptive group, which is the oldest group, compared to the untreated group. So overall, I also showed this. It shows the same thing, so I won't go through it again. But overall, the answer is no. Like Dr. Reynolds had pointed out, that clearly the two groups were not at the same point in an age group. So the next question was the patient follow-up sufficiently long and complete? Remember, this is a 24-month study. We talked about the compliance.
I think 2 years is decent, but I would like to see further years too. I don't know how realistic that would be, considering half of them dropped out in this case.
Why would you want to see it longer than 2 years?
Because, like you mentioned, you don't start losing bone mineral density until you're older, and so I wonder about like the actual clinical implications of this. Like, are these girls going to have increased risk of fractures, or just going to have lower bone mineral density? The authors did some sub-analysis of like what happened over the first year versus the second year of treatment, and what's different. So, like, what would happen during the third year and the fourth year? You know, do you continue to lose bone density, or do you stabilize, or do you lose it back? So.
We'll talk about that in a little bit. Anybody else have any other opinions before I move on? So I concluded the same thing, so no, it was not long enough. Of course, our goal with oral contraceptives is to avoid pregnancy, and usually females are trying to wait until they're around their mid-20s, or at least out of their teenage years, so that's usually going to be more than 2 years of oral contraceptive use. So I would like to see a study that was longer as well. And to the question of whether it was complete, I answered no to that as well, because clearly a good number of participants dropped out of the study either because they didn't make it to appointments or they decided to change the method for which they were using at the time.
So the question, even though there were 3 groups dropped out, they did an analysis and found that the difference between the ones that dropped out and the ones that stayed in was essentially the same. So really you just lost power? Okay.
You don't know for sure that they're the same. You know based on the data that you have.
Right, which is all you have to compare it on.
Yeah.
So it's like
but there could still be something different about that group that dropped out that could be important.
Could be.
But you don't know.
And this is just only a reflection of the adolescents, right? It's a forced study. They're watching them. They're not forcing them or giving them incentives to take anything. So they might start on contraceptives and change their mind and do IUD, so they might, stop people. But you can also see the possibilities of abandoning the method, right? The ones who were taking nothing, they started to start doing something, half of them, in the course of 2 years, right? So that's actually how the population actually moves. Whether that helps you for your analysis, that's another question, right?
So next question would be, were the outcome criteria objective? So let's think about. Yeah. So, yeah. That's what I said too. So, yeah, bone mineral density is not something that's modifiable by the opinions about the patient or whatever it may be. And then if the subgroups were different, with different prognoses are identified, did adjustment for important prognostic factors take place?
I don't know. I know had certain things, but I don't know if they adjusted for it because they would just say, oh, some of these people were active, some weren't, smoked, some didn't. I don't remember the adjustments.
So yes, so they did include the confounding variables that they collected at the beginning of the study. So the chronological age, the weight, the race, physical activity, and tobacco use. However, they did not provide us with subgroup analysis comparing the older age versus the younger age, which would have been nice to see as well. So overall, what were our results? The injectable group had a decreased bone mineral density, and of course we know normal in adolescents is to increase your bone mineral density. The oral contraceptive group had an increased bone mineral density over the 2 years, but less than the non-treated group. And of course, looking at the study, they didn't really provide us with the significance for that, comparing the oral contraceptive group to the non-treated group. And then looking at Table 2 in more detail, the spine appears to be more stable than the femoral neck, which is something that Dr. Reynolds had already brought up in conversation, but noticing that the rate of decrease in the bone mineral density declines over 2 years compared to that of the femoral neck, which actually decreases even more. So just to kind of focus in on that, looking at Table 2. So you'll notice that from baseline to 12 months for the spine, there's a mean change of 0.02. And I don't remember what the actual percentage that they calculated for that was, but I think it was negative 1.4% compared to from 12 months to 24 months, that change was 0.01. So you can see that that there's a slower rate of decline in the second half of the 2 years, compared to the femoral neck, where it goes from 0.92 to 0.9 in the first 12 months, and then you'll notice that it appears to increase more rapidly to 0.86 in the last 12 months. And then finally, to look at the external validity of the study, can we apply this to our patients? Anyone? So I agree. So yes, we have a similar population. We're looking at teenage females who want contraceptive and they want to avoid pregnancy. And of course, we also have to consider that pregnancy also has its own negative effects on bone mineral density, as well as other complications, medical and non-medical, for those patients. So now that I'm aware of that, that's likely to lose bone mineral density with the injectable group compared to the oral contraceptive group. But if adolescents will be more compliant with the injectable group, I think that that's a better option overall, because it avoids pregnancy, which has its own problems. And then we can always consider offering them supplements to help with their bone mineral density, and consider assessing them for that loss and adjusting accordingly. And then, of course, from the study, we can also conclude that girls who have lower weight or low BMI are probably not good candidates for the injectable contraceptive. We'll pass it on to Dr. Casal.
One thing I will add here to you is the article with, one thing I will add to this article is that this was one of the most pivotal articles that came out. So you can see it was 2008 when this came out. This is after, in 2004, there was a black box warning against Depo, and you saw a significant decline in the use of Depo-Provera, but you also saw an increase in pregnancy. And so I think you have to look at it from the standpoint was this helps clinicians decide what to do next with these patients. That was one thing that I constantly learn in training about this particular article. I think, again, if you go back to that last slide, because that'll help me, we use Depo. This is probably the number one method that we use. So anytime you're choosing contraceptive options, you have to choose what you think is going to work for that patient. This is helpful, but at the same time, if I can offer those supplements, then I'm going to offer those supplements because I don't want that kid to get pregnant, and you have to consider that. As far as assessing bone mineral density, I've asked several colleagues about that, both in adolescent GYN and what they're doing. Pretty much what we found about Depo is as soon as you stop that method, their bone mineral density pops back up. And so you're not sort of losing a lot, and so people don't see the utility of assessing bone mineral density or DEXA scans in these kids because, one, it's probably a waste of money, and they're going to pop up, and there are no regulations as how often these these DEXA scans should be done. So there hasn't been any guidance regarding that. So we just are really working towards increasing their supplements when we're talking about Depo-Provera in general. And yes, you have to be aware that in your eating disorder population, certainly we have a lot of those kids, and so maybe Depo is not the right thing, but we have to start them on something. And so you can consider at that point LARC methods, so Mirena IUD or Nexplanon may be good options for them, or your good old-fashioned OCPs if they're compliant. And the last thing I would say about this particular study is I sometimes, if the study was to go on for 5 years, we probably would have 2 people enrolled in the study. So any time you're actually doing research in adolescents, I think 2 years is spectacular. To have had these kids to come back for appointments, we can't even get kids to come back for a whole year if they're Depo-Provera on time. And so to have these kids to come back over a 2-year period and to say that they're actually taking their OCPs, which sometimes they don't, but they're going to say that to the person that they're talking to, and that's asking them questions. So I think just from the standpoint of reality, like you were talking about, I think 2 years is probably adequate. It probably does not check off all of the things that you want to check off on your as your measurement of how this study affects your clinical practice, but I think 2 years is a very long time to have attrition of a highly vulnerable and highly mobile population.
No.
I want to raise your parade. Hi, I'm Dr.
How are you?
from GYN. Thanks for inviting me. Very interesting. So I have to have full disclosure. If you look at reference number 12 in that paper, I am the guilty party for the black box warning. So when I was a fellow in Louisville, we actually did the study that originally created the data on bone mineral density and bone loss. And the interesting thing that we did is that we opened a Pandora's box that we didn't intend to do when we did the study. We just had a question, and it was an interesting question, and we answered it, and then we got ourselves into trouble because then everybody stopped doing Depo-Provera. Since then, there has been a lot of very good evidence that 2 things happen. One is bone recovers if you stop Depo-Provera, pretty much almost to the same as controls. So we have that data, and it's very strong, and so there is no reason to have significant, regardless of duration of use. So even if it's more than 2 years or 3 years or 5 years, regardless, if it's discontinued, they catch up and they accumulate bone. And the second thing that we also discovered is there's no clinical correlation with the decrease in bone loss and morbidity in patients. So patients studied all the way to postmenopausal range who were exposed to more than a decade of Depo-Provera did not have an increase in fracture risk. So that just tells you that although we have a clinical finding on a test, potentially the repercussions clinically are not as significant as we got ourselves to believe they were. So the American College of OBGYN actually came in very strong to not recommend stopping Depo-Provera for any particular reason. If this is the method that the patient needs, that's the patient and the patient needs, because consequences of pregnancy or not have contraception are way greater than the potential bone loss that is recovered with an average use of Depo of 2 years or less. So it's kind of throwing it into context of your patient population. Depo-Provera is a fabulous method of birth control. And we submitted a letter to the FDA from our Pediatric Residents Society to try to remove the black box warning. That didn't go anywhere. But we continue to try to have the FDA remove it because there was no clinical consequence except unintended pregnancy. That was the only consequence of this. So clinically, as obstetricians, we do not limit the utilization of Depo-Provera. We do not follow the bone mineral densities. We give it if they need it, and for as long as they need it, if we understand that this is the only thing they can have because all the other things are not working for them. So just so you get the kind of OBGYN perspective on this, as we have done this for a very long time. And we've been fighting now for almost 10 years to get this removed, and it's not working yet. So those are the 2 cents. And I apologize for creating a disaster with this study.
Those were great. Thank you. Okay, so we're going to just quickly switch gears, and I'm going to talk about your extended regimen, the 91-day regimen that's now becoming more popular in our adolescents, and comparing that to your typical 28-day regimen, OTPs, and its effect on bone mineral density. And we all know that bone mass does depend on estrogen, and there have been studies in the past that combined OCPs have either no effect or small negative effect on increase in bone mass. However, there has been this increasing trend in using these lower doses of estrogen in our adolescents for various reasons that I'll talk about. And now these regimens who have the lower doses of estrogen have a more negative effect on bone mass, especially during adolescence. Thank you, Nicole. So this study was a phase 2 multi-center open-label randomized control trial done in 45 academic centers, clinical research centers, and community practices here in the U.S. It was a 12-month study that looked at 829 adolescent girls ages 12 to 18, and this was a non-inferiority trial. So this is where you guys are going to learn the non-inferiority trial. Just a quick recap, remembering the phases of clinical trials. Phase 1, we're assessing safety and dosage. Phase 2 is the efficacy and side effects, which is what the study is. Phase 3, that's okay. Phase 3 is the efficacy and looking at this adverse reactions, and then phase 4 is the safety and efficacy. So very briefly, a non-inferiority trial, I did not know this before this article, so its purpose is to demonstrate that the experimental treatment is not substantially worse or inferior compared to your control treatment, I'm sorry. And this might be because the alternative or the new treatment may have its own advantages, including cost, compliance, maybe a better safety profile. So in this study, we're comparing the 91-day regimen, which you can see I underlined the doses, versus the 28-day regimen that we're most commonly familiar with. And so you can see that the 91-day regimen has 150 of the I won't say it, and 30 milligrams of the estrogen, followed by a lower dose of the 10 milligram for 7 days. And then you can obviously see the typical 28-day course.
So one thing in here really quickly.
Yes, ma'am.
So I want you to be very conscious about that they're using a 20 microgram tablet. So typical dosing for your standard orthocycline, things like that, things where you are 30. So this is considered ultra low as opposed to a low dose. So when they're comparing that, you have to keep that in mind, because this is certainly not something that we give out every day on a routine basis. This is what it is. This is considered one of those kids that come in, the mom says, I want the lowest dose possible for her. And that's what they're comparing this to. So I think that's critical to know about before you say, this is what we typically use.
Yes, thank you. And just for those who may not know what an extended regimen is, so this is this is indicated if you want to have cycles that's longer than your 28 days. So you have an increase in the number of the active combined pills. The point is that you may have fewer periods, or you have less side effects like headaches, or maybe they're not as aggressive, who knows. But up to 90% of surveyed pediatricians and gynecologists apparently do prescribe this to adolescents. And again, the most popular is the 84-7 regimen, but I believe the 7-day is not active pills for the more popular ones. Right.
So there is one product that has 7 days of very low dose amount. It's called Stephanie.
There is a...
Describing brand name is seasonal, so there's a generic equivalent of that. But the seasoning remains brand name, and it has a little bit of estrogen, I think 10 micrograms during that placebo week, theoretically to prevent break completion.
Got it. Okay, so we're going to go through our methods here. So as you can see, we have our inclusion and exclusion criteria. So basically, we have healthy adolescents ages 12 to 18 years old, obviously menstruating, and should have at least a 3-month history of regular spontaneous cycles. Their BMIs ranges from 18 to 30. Their weight was limited to any adolescent who was less than 90 kilos, and obviously they don't have any contraindications to OCPs. And this inclusion criteria was a way to control other confounding variables, including those who may have chronic diseases, who are obese, that may impact their baseline bone mineral density. And then the exclusion criteria, obviously, lactating moms, pregnant teens, and other patients who other adolescents who may have chronic diseases that take chronic medications that may affect their bone mineral density. This little figure here kind of nicely shows how the study design was. And so when when criteria was met and confirmed, each adolescent were randomly designed using a block size 4 in a 1-to-1 ratio, either in the extended regimen versus the 28-day regimen. And they all started their regimens on a Sunday. They took 1 pill for 52 consecutive weeks, and the clinic visits you can see here were done in the 3-month intervals. And then this is where they assess the compliance, as well as how adherent they really were, and if they were experiencing any adverse events. And as you can see here, they also did the DEXA scanning at baseline after they were randomized, and you can see at 26 weeks and at 52 weeks where they ended the study was when they did the follow-up DEXA. Our primary outcome for this study was the mean % change in lumbar bone mineral density from baseline up to the end of the study, which was 12 months, while the secondary endpoint was the bone mineral content. And I will go through that a little bit in detail. And just to remind everybody about the non-inferiority trial, again, this study is to compare the effects of the 91-day regimen versus the 28-day regimen on the bone mass density. So this study used a 3% non-inferiority margin, and this number was actually based on previous studies that reported a 7% difference in the lumbar bone mass density between those females with and without a history of fractures. Does that make sense? And so they use a more conservative number, expecting that this population is probably at less risk for fractures in general. And so this means that if there is a greater than 3% in their bone mass density in the treatment group and the reference group, that it is clinically meaningful. It's also important to note the type 2 error in this study. Don't forget that type 2 error occurs when a study erroneously dismisses an actual treatment effect that might actually be potentially useful. So in basic terms, like Dr. Jaime said, they may seem like there's no difference, but there really is. Anything to add with that, Dr. Jaime? Okay. So let's go through our results. So of the 1,441 adolescent females, there were 1,361 who were screened based on the inclusion criteria and were enrolled in the study, and about 1,270 were evaluated for safety, while am I losing my number here? Sorry. well, 829 were included in the analysis population. And so 906 of these female adolescents were randomized to either the treatment regimen versus reference group, and about 63% of them actually completed the study, which is quite good, and 36% withdrew, the most common reason being loss to follow-up. So looking at our the basic characteristics or the baseline characteristics of our population, it seemed as if when you look at it at first that it's comparable. However, it's just like Dr. Sanders' article. It's important to note, and I tried to include the p-value of the little signs here, that compared with the reference group, our treatment groups were also older, and they're at least a year older, a year younger. The reference group was a year younger on average, and there was a statistical significance between the mean age of the treatment groups versus the reference group. And remember, this does matter because younger teens tend to have less bone mineral density, anticipating that they will have it later on in their subsequent years. Also, there's a statistical significance between the races of the groups in the reference group. For example, you only have 3 Asian teenage girls in the reference group right here. And obviously, if you look at me, my bone mineral density is probably low, just because of my stature and my petite frame, whatever. But another really important history or characteristic is their smoking history. Again, like Dr. Sanders' study, the older kids tend to report a smoking history versus the younger kids. And again, we know this is important because of the effect of smoking on bone mineral density. And when you briefly look at everything else, it looks like the rest, like menstrual history, calcium intake, physical activity, were generally similar. So this is just the graph of that depicts more of the percent change in their lumbar spine bone mineral density in all the 3 groups. This is your reference group who did not get treatment. So you can see that there was a more of an increase in the bone mineral density in the reference group who did not get any treatment versus the other 2 groups. The extended regimen group had more increase in bone mineral density than the one who had the ultra low, like Dr. Crew had mentioned. And so you can see that perhaps this is not statistically significant because it crosses your zero, so you have negative 0.2 versus 2.67, but the other 2 groups here comparably are statistically significant. And even comparing the extended regimen group versus the 28-day group, there was a statistical significance. Oh, I had things to highlight it. And just very briefly, again, the non-inferiority trial, excuse me, remember we're just looking at the differences on bone mineral density between the 2 treatment groups. And this table 2 nicely lays out in detail the treatment effect of the percent change in bone mineral and bone mineral content. We already talked about the top 3 in the graph format. But what about femur bone mineral density right here? It pretty much, it's same is true as our lumbar spine bone mineral density. There's it's not clinically meaningful at all, especially between the same groups, between the reference group and the extended regimen group. But what about bone mineral content? Remember this is our secondary endpoint, and the change from baseline to the end of treatment was essentially the same, reflected the same thing as the bone mineral density. So essentially the data behaved the same way, right? Did I explain that correctly in so many words? Okay, tried really hard. Okay, so I wanted to highlight adverse events. 9% in the extended regimen group, and 7% in the 28-day group withdrew from the study because of adverse events. The most common ones that they had mentioned was 6% in the extended regimen group reported metrorrhagia versus 3% in the 28-day regimen. And the other side effect that was pretty significant was headaches, which was reported more in those females or those teenagers who were in the 28-day regimen. There were no deaths, thankfully, and it's good to note that there were 16 pregnancies in all groups. So we're going to try to appraise this. Did the novel and standard treatment groups start with the same prognosis? Yes, no, maybe so. I probably confused everybody. What happened? Sorry, guys. Okay, I said yes, but then not really. And so we already discussed this, right? So we already mentioned that the reference group was a year younger. The demographics were quite different in your treatment and your reference groups. And I didn't mention this earlier, but the mean BMI of the extended regimen group was statistically significant from the reference group. And so when you look at this, you see more similarities between the two treatment groups versus the two treatment groups and the reference group. Was prognostic balance maintained as the trial progressed? Dr. Okay, it's okay. So I said yes, but then again, not really. I read this question and thought, meaning, they treated them all in the same way for the majority of the part. But then again, we talked about other factors like smoking history, and they did account for calcium intake and physical activity, but how about vitamin D exposure? How are we going to measure that even if we did? Did the investigators guard against an unwarranted conclusion of non-inferiority? I said they did. So they had a higher power and a lower significance of 2.5 versus 5%, so they did. Was the effect of the standard treatment preserved? I say yes, too. Good. And then did the investigators analyze the patients according to the treatment they received as well as to the groups to which they were assigned? Oh. So we said no. And I had a really hard time kind of thinking about this, so Dr. Jaimes can help. So remember that 36% did withdraw from the study, and we don't really have the data for this. They didn't have an intention to treat analysis, so analyzing the data independent of what these subjects do. So even if they didn't want to follow up, you follow up even if they didn't follow up, is what Dr. Jaimes is saying. But I'm going to let her explain that because it did not make sense to me. I'm just being honest.
So there is two kind of analysis they did here. They did a safety analysis where they actually included everybody. The 1,270 kids were included in that safety analysis. There they took care of the side effects and all the characteristics, and they used that. That was a complete analysis of everybody, including the ones who didn't complete the study, right? But they did another one they called the bone mineral density analysis. And for that analysis, they only took the ones who finished the study, the ones who complete the follow-up. There's one thing that I think is lost in here. They only lost follow-up of 15%. However, they actually lost analyzing, like close to 37%. So they could have analyzed the data of everybody but 15%, which gives them a much better, source of data. However, they only analyzed for the what they call the bone mineral density analysis, less percentage of that. But, I mean, it's just a phase 2, open label, not blinded. This is the first step to go further. So can we still have some conclusions with this study? I think we can still talk about it. So that's why we're reading it.
Thank you. Were the study patients similar to my patient? I think you guys have the same answer to this. Is yes, we do treat adolescent and see adolescent females. Were all patient-important outcomes considered? Maybe is what I said. We didn't really assess how effective it was on pregnancy. We knew that 16 of our female adolescents did become pregnant. We didn't account for other things like maybe using it for treating PCOS, how many of those females who withdrew from the study had breakthrough bleeding, weight gain, headaches, or treating it for acne. Okay, I clicked too fast. Are the likely advantage of the novel treatment worth potential harm and costs? I said I don't think so. So, based on all of the information we have from Dr. Sanders and I's talk, we concluded that contraceptives are associated with lower bone mass density, but so does pregnancy. In addition, contraceptives have been shown to effectively prevent pregnancy, of course, and you really have to evaluate the risk versus benefit. What are you using your contraception for? Is it for to prevent pregnancy versus treating something like painful periods, heavy periods, those patients who have PCOS or acne, and again, some of the things I briefly discussed with Dr. Reynolds in passing is, OCPs can really give you some protection, or has been shown to give you protection against ovarian and endometrial cancer. And then just like Dr. Sanders mentioned, you do have less compliance with those who has to take a pill every day versus those, the injectable where you have just to come in the office every 3 months. Those are our references, and we're open to questions, concerns, comments. I'll be your walker.
So this study was looking at change in bone density over time, which makes sense for what the question was, but I want to make sure everybody understands how we typically look at bone density in adolescent females. So especially for the students, like if you're doing a DEXA scan on an adult, you're looking at a T-score, which tells you the number of standard deviations compared to the average, healthy, like woman in her 20s. And when we're looking at children and adolescents, you're looking at a Z-score, which is standard deviations compared to somebody of that same age. So that's why the age is important, because you are building bone density a lot during those years. So, you can't compare somebody of one age to somebody of another age when you're talking about a child versus an adolescent. So what we're typically looking at is Z-score. And the other comment I'll make, I don't know how often other people encounter this, but a lot of patients that I encounter are patients who maybe have a severe chronic medical illness, like they have severe cerebral palsy, and a lot of times the parents are wanting just cessation of menstrual cycles. And so those are ones that I struggle with a lot, because the parents are not wanting to have periods, but you're, for the most part, hopefully not worrying about pregnancy prevention, so that's not a big benefit, but they're wanting to do depo, and these are patients that are super high risk because they're non-ambulatory, they probably have osteopenia, and so that's a group where, I think maybe you need to think twice about depo, or maybe get a DEXA scan so that you can show them that their Z-score is, -4, and it might not be the best option for them. Maybe.
I want to piggyback on your comment. I think I'm loud enough. Are you recording this?
Yeah.
Oh, you are? Oh, somewhere else? Oh, okay. Hello. Anyway, so I'll piggyback on that. These are the hardest patients to take care of, is those who are disabled, who the only thing they want is no menses. And not only do they have a problem with their bone mineral density, but they tend to gain weight with Depo-Provera because they are not as active as their peers. So these kids not only are difficult to care for, but now they're getting heavier and heavier and heavier while you keep them on Depo, and their bones are getting weaker. So it's an interesting balance. I get at least once a month a consult for a hysterectomy in a 12-year-old. So that's common practice. We get them in. Dr. Reynolds and I share patients sometimes about some of these kids that are autistic or severely disabled that are seeing her for growth issues, and they're coming to me for menses manipulation. So this is extremely common. One thing we have moved a lot towards is using IUDs in these kids to try to do the best we can in order to maintain that, and that seems to work, but the problem is the uterus needs to be mature enough to accept an IUD, and you don't want to use any other IUD except the 5-year 52 milligram levonorgestrel IUD because the other ones are not as good for amenorrhea rates. So instead of fixing her, you break her because you give her more breakthrough bleeding. That's doesn't help. So they need to sometimes be in their 14, 15 year of age before you can act. So you have still, and it is not uncommon that these kids start menses earlier than their peers and have precocious puberty as one of their issues. So these are very hard, tough cases to take care of, and the parents are the kids care less. It's all about the parents' management. So these are very hard patients to take care of. But thinking of these is important in the context of using of low dose oral contraceptives and Depo-Provera in patients who have other comorbidities that contribute to bone loss and weight gain. You got to be cautious with that. There is very good data showing that adolescents really do not gain the same amount of bone mineral density on 20 or now the new 10, low estrogen is called. That is a 10 microgram pill instead of 20. So there is pretty good evidence on that. And these few trials, this is just one of the maybe 8 or 10 different trials that have looked at different doses of OCPs and bone Accurol. And they're all pretty consistent to show, although their studies have flaws and they have some issues with Accurol patients and all that, they're pretty consistent to say the lower the dose of estrogen in the OCP, the less bone they get. That is pretty clear. So as you think of these patients that come to your office, they want the super ultra low dose because that's what the parents want. You know, there is no purpose. They bleed more. Maybe side effects will guide that, but not necessarily needs to be the first choice for your management on these kids. It's just.
And I just want to add one thing that I don't want to miss saying is that it's very important to take into account the age of the child to decide what to give them for contraceptives, or discuss this with the child and the parents. And knowing that if they're younger and they have less bone density to start with, you know, it's probably better to use another one that will allow them to get some bone density, one thing. The second thing is that there is an aversion against IUDs. I don't know why in the United States, noticeable related with the rest of the world, that I found really, controversial. I don't understand why. Well, it is, which is, not a problem that we have down in South America. It is very effective, and it can be, used with or without hormones, and it's very safe. And, all these issues about infections, and that is all already studied, and it's not proven to be the case. So going back to, open up the conversation and propose something that could be safe for them, and at the same time, accomplish all these goals of not having periods and, whatever the interest of the teenager will be. And of course, remind them to use condoms, right? Anyways, whatever they use, right?
I agree. I agree with what everyone said. I think that I would be curious. I don't know of any studies, and you probably know any follow-up studies for special needs populations where they have studied sort of the actual occurrence of more fractures in kids that have been on Depo-Provera more than 3 or 5 years, because I know, again, I keep these kids pretty much for the sake of the parent, because they're not quite ready to do that IUD. That kid is 14 years old, and you're trying to convince them, hey, we need to think something else, and they're still like, I want to continue. And I really don't have a study that shows them, hey, this kid has been on there for 10 years now. we got to think of a master plan. And because that evidence that I know of isn't there, it's even harder to convince some of these parents that have these special needs population, even with their risk factors of being immobile and having weaker bones, that this is, I think, just difficult to convince them of that piece of it. So,
I mean, the discussion for that first article, they did point out that there was a study that said if you have a 7% change in your bone density, that a 7% change in bone density does translate into an increased risk of fracture. So it's extrapolating quite a bit, but that might be something you could tell patients, and then they said, well, in our study, we did see a 7% change.
And I think the other thing that comes up is sort of racial and ethnic differences in bone mineral density at baseline.
Yeah.
And so, I have an African-American person that is reading articles that, I don't have any fracture risk necessarily, versus I have a Caucasian parent that says, well, I'm a little higher risk. So I have to convince those two different people of different, and I think one of the articles actually gets to that difference and whether or not we would have seen a difference. A significant racial ethnic difference in fracture risk would have been interesting to me, I'm sorry.
I'm sorry. I'm really not.
Oh, that's okay. But, I think that a part of it, I see pretty much a wider variety of patient racial and ethnic backgrounds, but I definitely have a stronger African-American background as far as patient population, and those patients and their parents are like, look, she got thick bones. So, is it really gonna matter if I keep her on depo? I don't want to have a grandchild at 16 years old, or, I'm tired of dealing with periods now. So I think all of these are just good questions, and it feeds your knowledge as well as helps you to care for patients. And you just do have to take all this into account when choosing the correct option for your patients.
And there's nothing wrong with being sequential. It's sometimes we fixate ourselves that we need to do something and the patient is taken care of and that's it, and they only have one option. The most common sequence that we see in PGYN is things that we do. Sometimes we start on the continuous oral contraceptive pill to control menses, and then we move on. That didn't work. We moved to Depo because they didn't want an IUD, and then we moved to an IUD a couple of years later. So sequential utilization of your armamentarium, it's appropriate, and there's nothing wrong with that. You don't have to lock yourself into a single way. You don't want that, then I can't help you. So it is not uncommon for us to, bridge them from 12 to 15 on something different, and then at 15 we put an IUD and we change it every 5 years under sedation. I mean, and then we do their pap smear at the same time, and the dental cleaning and the whatever else we got to do for them. So this is something that we're very used in GYN because a lot of these patients need other primary care needs. During those exams of anesthesia that we do for them. So there is options always. Don't feel locked if you're not comfortable. There's plenty of us that can help out, between endocrine and adolescent medicine and peds and OB and all that can help with that. So don't feel locked in that I have nothing to offer.
And I think that's all what we have time for. Thanks, guys. Great discussion.